move up into the thoracic spine now, and we'll look at some alternative assessment techniques and treatment techniques to what we saw on the previous tapes. Again, we'll be integrating the basic position tests and coming up with the same diagnosis, a positional diagnosis of an ERS or an FRS. And then we'll be testing those particular hypotheses out passively. Okay, so if we move to the patient, we'll have the patient just come down the bed a wee bit this way. A little bit more for me, Billy. Get the patient in close to you. We'll get her to cross her arms over her chest this way and then thread in between the arms. Now let's assume that what I found was an ERSL at, say, this level. Okay? And I want to check to see whether this is actually hypomobile. What we'll do is we'll take her to the extremes of flexion, right side bending, right rotation for that segment. And that's my passive movement technique. So this is what I'll check passively. And I'm feeling for the spinous processes to move relative to each other. Now, if I'm not getting that relative movement, I can start thinking that I have a hypomobility. My next question is, what type of hypomobility is it? Is it articular or is it extra-articular? To test this, I need to do the arthrokinematic glide. This isn't easy for flexion, except unless you come onto the posterior transverse process. Now, remembering that an ERSL is because the left side of the segment is unable to flex. If it's articular, it's because the left joint is unable to flex. So we'll bring her to the end range for that position, flexion, right rotation, right side bending, and I'll basically come onto the transverse process on the left and push it forwards and up and get an end fill from it and compare it to the one above it, which is in the same end range position. And I'm looking for a normal capsular end fill. If I'm not getting this normal capsular end fill and it's harder than it should be, then essentially I'm looking at a pericapsular hypomobility. If it feels jammed, then I'm looking at a subluxation at this joint. If this felt normal and the passive physiological movement was restricted, then essentially I'm looking at an extra-articular or myofascial hypomobility. If when I tested this ERSL out it was normal, the passive physiological movement was normal, then basically I would have to turn around, flex and rotate to the left to see if I was getting too much movement, in which case this ERSL would be caused by a hypermobility on the right side. If this was an FRSL, then I would do much the same passive physiological movement test, but this time I would rotate side bend to the right and extend her. So I'd be doing this movement with her and palpating these spinous processes for relative movement. And again, if I wasn't feeling it, then I would have to wonder, why not? Is it articular or extra-articular? Now, I can't really come onto this right transverse process, which is the hypomobile side, and pull it downwards. I'm still going to have to push on this right one and hope that I can push on the left one and hope that I can swing the right one downwards indirectly. And I'm going for the end fill again. I'll push forwards and up and check it with the one above it. And again, depending on what we find from the arthrokinematic test, if it's positive, we can start thinking about articular hypomobility. If it's negative, then we can talk about myofascial hypomobility. If we found that the passive physiological movement test was negative, then we again spin them around and look for hypermobility on the other side.